review of the material from yesterday, okay? Real quick. And I have notes if you need that. Just concentrate. Okay. So let's get started real quick, and then we'll take a break after. So we're going to do our recap from yesterday, because I gotta go get it. Plus, I don't want to be doing that when she walks in. Hey, here's the answer to your test. Oh, man. Just make you think about certain things. Yes. Research it first. Call it, and then you just go try to what you can study every detail. Okay, so did everybody get the notes that I had from the level 1's A&P on neuro? I made copies of my notes. If you need those, I have some somewhere. And that's just a good review for you because I know it's been a while since you were in level 1. And there's a lot of information that's been put in your head since then. So, are y'all ready? A neuron is a basic cell of the nervous system. The CNS is your brain and your spinal cord. The spinal cord can handle the small stuff. Remember, Stephanie was doing fine and on her own with simple things like reflexes. But then when it's got too much to handle, what does she have to do? Let the brain take over. And so it's a complex thing where there's multiple messages or information coming in. The brain has to take over. And it gets help from some of the glands that secrete adrenaline. Okay? And that's what goes and helps go out to all the body parts that need to move faster, breathe faster, beat faster, get us to safety. Okay? The peripheral nervous system, that's the rest of the body if it's not brain or spinal cord. Somatic nervous system, that's where the neurons sensory come in. Any kind of sensation, you're touching a hot stove, that sensory neuron shoots back into your spinal cord. There's central neurons that are in the spinal cord that process that message, and then the motor neurons send it back out. That's the somatic. It has those sensory, central, and motor neurons in it, okay? Just like text messages, just constant back and forth. Autonomic nervous system, that's the one that is pretty much unconscious. We don't even have to think about it. So it's kind of automatic, autonomic. That one has the sympathetic and the parasympathetic. And the sympathetic, I gave y'all the handout for that. Which one is that? Speeds us up. Fight or flight. That's the one that when you're in crisis, it takes over and tells everything to speed up. And then parasympathetic is the one that slows you down. Rest and digest. And so you can't stay in a state of adrenaline rush all the time. You have to slow down. So those two work in tandem. In your book on page 1896, there's a picture of that cell. And the top looks like a tree. That's the dendrites. And you've got the long chain, the ganglia or the axon, and they're wrapped around with a myelin sheath that helps protect it. And then all of those, that's one little cell. So all of them can join together and form a chain. And that's how you get those messages back and forth, right? What is this part that produces the CSF? The glial cells. Neuroglia.
The glial cells?
Glial, yeah.
How do you spell it?
It's Neurogia, neuroglia, or they're called glial cells. Those are the ones, they're in the nervous system, but they are the ones that help produce the cerebral spinal fluid. The neurons are the ones that carry messages, okay? Dendrites are the top branches up there that receive all the information, and the axon is kind of like the cable that takes the message back and forth. So we said myelin sheath, that's the white waxy substance that circles around or covers it on the axon, and then which cells make that myelin sheath? Schwann cells. And then even around the Schwann cells is something called neurolema. Those are what help regenerate those in the peripheral nervous system.
Are the Schwann cells covered by the myelin?
No, it's myelin sheath, then the Schwann, and then the neuron. So it's layer. And then Remember what I said, like if you get cut somewhere on the peripheral, those nerves can regenerate, right? But if it's an injury to the brain or spinal cord, you're done. That's why you have paralysis in certain areas to injure those type cells because they don't regenerate. Okay? And remember, this might be something that comes up on ATI. The myelin sheath deteriorates. When it starts deteriorating, that's when the muscles are atrophying and there's no messages being back and forth to that muscle from the CNS. So that's when you get the muscle atrophy, muscle deterioration, all the different kind of muscle disorders. Okay. Now, we didn't talk about this much, the synapse. So, like if these were your neurons, and they're all on a chain together. So that picture on page 1896, the weird looking one that looks like a tree, each one of those were chained together. They bond together, okay? The spot where they bond together, neuron to neuron, is called a synapse. Okay, that's where that impulse jumps back and forth from synapse to synapse. Once it gets to the end of its line, okay, I'm coming back from the spinal cord, now I'm at the muscle. He's the muscle. There's a gap between the end of the neuron, the last neuron, and the muscle that I'm wanting it to move on. So that is called a neuromuscular junction. That's where your neurotransmitters are. Those are the chemicals that help facilitate that. Okay? So see why I didn't go into it. So the gap between each neuron is a synapse. That's just a jump. Remember I said they jump node to node to go faster. So that gap is a synapse. Once it gets to the end of the neuron, the last neuron on the chain, next to the muscle, it's a neuromuscular junction. And that last little one, it sparks off the message and sends it to the muscle. And with neurotransmitters, they are the chemicals. Okay? So if you see those, you'll know that that has something to do with the neurosystem. Those are like acetylcholine, serotonin, dopamine, epinephrine, things like that. Those are neurotransmitters. They help make sure that that impulse gets from the nerve to the muscle so that that muscle moves and gets to safety or does whatever it needs to do. Okay? Remember they have the all or none law. Cannot go just halfway and say, never mind. It's going to be, that message comes to me or doesn't come at all. There's no in between. It's all or none. It has to be strong enough to elicit a response to get to the CNS, or it just sits there and atrophies or gets hurt. And if you don't move your foot off that hot pavement, what happens? Your foot just burns. Yeah. So there's all or none law. Do y'all remember hearing about the blood-brain barrier way back when? That's that protective thing that around your brain. It's on page 1899. Prevents harmful substances from getting into the brain. A lot of drugs, that's a big deal if they pass through the blood-brain barrier back and forth. Y'all remember that from farm? Anything ring a bell?
We didn't have farm.
Blank. Okay. So just know, blood-brain barrier protects the brain. There are some meds that go across it and some that don't. There's some, and if a virus or a bacteria gets across it, the brain is divided into 4 parts. The cerebrum is the largest. That's the one when you look at a picture of a brain, you see it's like the 2 big hemispheres. And they've got that bridge in the middle. Do y'all know about the cerebrum where if you have an injury, let's say you had a stroke on the left side of your brain, where would you expect to see the effects are on the right? That's because it's in that cerebrum. That's the part that is, the hemispheres are crisscrossed. So know that. Cerebrum is the largest part of the brain, and that's where the hemispheres control the opposite side of the body. And then it has 4 lobes: frontal, parietal, occipital, and temporal. Frontal, so like a frontal headache, frontal head injury. Occipital's the back, always, right? Temporal, right in here, and then parietal. All of this is in your book, and you can go back, and I'm just trying to hit what you need to know about each part, the most important part. The diencephalon, that's called the inner brain, and that's where your thalamus and hypothalamus are. That's the body temp control area. They do other things, but That's where if you had a head injury patient and they have that thing that's malignant hypothermia because they just spike up or temporizes sporadically, that's because that part of their brain, the hypothalamus that controls their body temp, has been injured. So that tells us that part of their brain is what they have a stroke in or an injury. Okay. Cerebellum, that's just the autopilot that kind of controls all your subconscious stuff. And then the brainstem is at the base, and that's where a lot of your awareness, your memory, that fund of knowledge is all that is at the brainstem. Okay. Any questions on any of that? And then I gave you the handout for the cranial nerves. Remember that they're in the head and neck, except for one. Which one is it? Vagus, baby. It's number 10, and it's the oddball. It goes into the thoracic cavity, so it controls the heart, blood pressure, heart rate, and then it goes down into the GI. So when you vomit or get real nauseated, that is stimulating that vagus nerve there. And then it even goes down into the rectum. So like we talked about, if you overstimulate the rectum, whether it be from a procedure or any other activity, you can vagal down. Okay? It lowers the heart rate, which lowers your blood pressure. You can pass out. How many pairs of cranial nerves? 31. And they feed off. You have a pair because one goes to one side of the body, one goes to the other side, right? Right and left. They get information in and out. And then the 12 cranial nerves. How much does our brain weigh? 34 pounds. And it atrophies with age. We know with normal aging, even if you didn't have Alzheimer's or any of the other cerebral disorders, that with age, all of us, our brain is going to shrink just a little. We actually lose about 1% of our neurons after the age of 50, per year after the age of 50. So we kind of start deteriorating. That's why your memory's not as good and you get kind of fuzzy sometimes. Can't remember what you went to the grocery store for. Okay? And remember what I said, don't get pushy with your elderly. They're not trying to be defiant. Some of them might be at one time or another, but most of the time they're slow because their brain doesn't work as fast as ours. Okay? So take your time with them. Making sure that when you're checking your assessment, you're doing your orientation, like the person, place, purpose, and time. Use open-ended questions. Don't just say, do you want some milk? Yes or no. So what would you like for breakfast today? Things like that. Make them think and tell you answers. Know your Glasgow coma on page 1903, because now you see how they're going to ask you those questions about that. And then also there's that four-score coma scale that was on the next page, and that's the one that they added an extra category because when you're on the vent or if you've had a stroke and you're nonverbal, you can't earn points on the Glasgow because you don't have any verbal abilities. So they added that one for the people who had been in the unit and had a little bit more of an issue, so they could get an accurate assessment. Okay, we talked about intracranial pressure. A change in the level of consciousness is one thing, but that just means your blood flow. But if you have a decrease in your level of consciousness, that means increase in intracranial pressure. Something has made the pressure in the head go up. It's pressing on the brain, which is pressing on all your nerves, and that's why you're not able to think or do anything because those nerves are not being able to get the impulses through. Okay? Whether you've got a bleed, a mass, just high pressure, any of that can make you have increased intracranial pressure, and then that's when you see that change in your level of consciousness. Okay? And I gave y'all that handout on the intracranial pressure yesterday. And then we had a question about widening pulse pressure. So I want to make sure. Did everybody get this for your test? When you have a widening pulse pressure, what that means is you've checked your initial blood pressure and pulse, right? And let's say when you first got there, it was 130 over 80. Then you go back in 5 or 10 minutes later because you're checking your neuro patients a lot more frequently, right? Especially if they started having some deterioration. You go back in and you check them a few minutes later, and their top number, which is what? Good. That is 160 over, let's say, 60. All right. So here, how many difference of points of that is that? How much difference in here? Yeah. So you see how it's widening? It went from 50 to 100. Then you go back and you check it another time, and now it's 190 over 40. Is that, first of all, a good blood pressure to have? No. And look how much point difference we have now. So that means that you've had a widening pulse pressure. Okay? The top number, your systolic, is going up because your heart rate's speeding up. Your body's realizing something's wrong. And so your heart rate speeds up thinking, I need blood in my brain. And the bottom number is what you're doing when you're actually resting and stuff. So when it starts going down like that and having a widening margin, that's your widening pulse pressure. That is dangerous. So always, that's why we assess frequently, and we always let somebody know. We report that if we see that it's getting further and further apart. Okay? Does that make sense? After I get home, I think about stuff, and I want to make sure y'all know it. All right. So how frequent? We said we're going to be. If we had a neuro patient, we're going to be checking their neuro checks. How often would you say? Yeah, every 15 minutes. Making sure they're not having a change in their condition, and then report anything that is changing. We talked about our speech. When they have a change in their speech patterns, that's definitely something we want to report. There's lots of different ways that they can have speech problems, and it goes into detail in your book. Remember that it's not just speech. It can be with writing, reading, comprehension. That can still be difficulty with speech. That's kind of all in the same category. Okay. When we check labs for our neuro patients, especially if they've had increased intracranial pressure, they're going to do a lot of diagnostic stuff. They check a UA, and we're making sure that their blood sugar is okay. Because remember, if you have high or low blood pressure, or blood sugar, that's going to alter your neuro status, right? So they check that, make sure their sugar's not too high. Check for infection. They may do a drug screening, drug toxicity to make sure that that's not what is altering their neuro. And then they do ABGs. Because remember, kind of tying into our lesson last week, when our kidneys aren't functioning, all of our ABGs get thrown off, right? And remember what we said, when your ABGs get off, it throws you into seizures. Decreased neuro status. So that's why they're going to check ABGs. If those are okay, then they're going to start doing the x-rays. They'll do a lumbar puncture, maybe, because that's real invasive, and we have to worry about it not sealing off. So after they do all the non-invasive tests, like x-ray and lab work, then they'll do a lumbar puncture to try to figure out what is causing it. What's the MRI and MRA? What's the M stand for? Magnetic. So remember, what did I tell y'all? That you can't, no metal of any kind. If your patient says, oh, I had my pacemaker put in 10 years ago, do not let him go in there. Because it will rip it right out of his body. So you make sure you call the doctor and say, I have an issue. Okay? So that's part of your assessment. Yes, it's a huge one. their skin. EEG, that's just the one where they put the electrodes on the scalp. No really prep for that. Just stay up all night so they sleep during the procedure, and then that just checks their brain. Yes, they need to wash their hair that morning because the electrodes will not stick otherwise.
Okay, so they have to stay up all night so they'll rest. So if they don't, is it not, you don't automatically put them to sleep with that? Like,
No, because we don't want to give them any kind of sedative because then that's going to do what? Alter the test results. So they
just naturally have to
yes,
fall
they
asleep.
just say stay up all night. You can't have caffeine or anything, but they tell them try to stay up all night. You know, find something, do a movie, do whatever, and that way, so they go into that really good deep sleep, and you get that real accurate picture of the brain activity. So that's why they tell them to do that. And that's to check, like if they have masks in their brain, which is causing the neuro changes, a bleed, something that's small, maybe an old surgery. Old hemorrhage that was just small, that's now starting to bleed again, things like that. That's what they check. Okay, and then headaches, we already kind of went over that earlier. No nitrites, no MSG, no caffeine, cool, quiet, dark places.
Sorry, I thought this chapter was in.
Cool, quiet, dark places, and then low to no stimuli. We don't want music, we don't want anything, just quiet, cool, calm environment, and a cool cloth on their head. Okay? You can have stress, cluster, migraines. I'm pretty sure I just had stress. Alright, so then for seizures, we kind of talked about that. Those are real common, and I gave y'all, this is what was in your book, it's on page 19, 21, and 22, but I wanted you to have it just so you'll have a quick. Do you want to do that? Are y'all ooh and on, act like everything?
Running point.
For real, I need all I can get. Okay, so there's the seizures. Sorry. And look, my PowerPoints aren't even up. So, for seizures, remember, the main thing we want to do, always turn them on their side, start timing it. We want to make sure that we know, watching through the seizure, know what they're doing. Were they turning blue? What's their respirations? Were they breathing through it or not breathing through it? Your information that you're seeing with your nurse eyes is what you've got to report to the healthcare, whether it be the EMT, the ER doctor, whoever. So what you see, that pertinent information is what they need to know. So tell how long it lasted, what they were doing before the seizures. That might have been a trigger. Like my little girl, she would, not my little girl, but my student, she would go outside and be playing hard. And we knew as soon as her body temp hit a certain, degree, boom, that was her trigger. So watch for those, and those signs, and make sure that you report those. We always put them on their side, we time it, we don't put anything in their mouth, we protect their head. One day we were in another kid, we had so many kids with seizures. I don't know what was going on in our school, but he just was in music and fell over and had a bad seizure, and so I had to take off my jacket to put it under his head because he was having a really hard one. And you don't want them to hit their head. The rest of their body would be okay, but the head we protect. So if you have a backpack, a purse, a jacket, whatever you can put to cushion their head, that's what you want to do while they're having a seizure. Nothing in their mouth though. We loosen their clothing around their neck because we don't want to impair that airway. Alright? Make sure we reorient them when they wake up because they might be confused and they don't remember what happened. And then you can ask them when they're a little more awake, like, do you remember seeing anything? Did you have an aura? Was there something that made you feel like you were about to have it? And that way that helps the caregiver or the doctor put a pattern together to figure out what is causing them, how can you avoid it. Alright? And then document and report everything. A lot of times the main reason they start having seizures suddenly, if they've had them in the past and they've been doing real good and all of a sudden they're starting to have them, is what would you think? What suddenly changed? Maybe they stopped taking their meds. They decided, I don't like the way they make me feel. They make me feel groggy all the time because they are a sedative. And so they can't drive without it, or they can't, it's a sedative. They don't have any energy. They can't live life. All their ADLs are altered and they don't want to take them anymore. So 2 or 3 days into not having it, guess what they have? Yeah. So you have to really push that and tell them not to quit their meds. that postictal stage, that's going to come up again.
How long does that last?
It just depends, and that's something you watch too. How long the seizure lasts and how long the postictal. Because the longer it is, it means the harder that seizure was internally. Did a lot more damage. The longer a seizure is, the more brain damage there happens too. So that's why time is important. Status epilepticus, do y'all know what that is? You seen that term yet? That's where they have one after another. They don't even wake up and come out of it before they're going into another seizure. And that one's really bad. That's what my little girl had that day that couldn't get them to break. We had to send her to the hospital, and they have to give propofol in the ER. Only be given in the ER.
Oh, you know that movie, the Thing Person movie? Have you seen that one? You know, watch it. It's about all that.
So, I mean, it's a big deal. They have status epilepticus, like I said, their brain is dying. Every minute that they have a seizure, they're killing brain cells.
Are you able to distinguish when they're going to play, or is it just
It just never ends, yeah. Like I said, they're usually a minute to 2 minutes. If they're over 5, that's why you call. If they're over 5 minutes, because more than likely they're not, if they haven't stopped at 5 minutes, they're not going to stop.
I see them for 8.
What, do you know what happened?
Yeah, we just sit down after 4 minutes or something.
It's very scary, especially because you anticipate it to stop. You're like, okay, it'll stop in a minute. And then when it doesn't, you're like, okay. And then you're like,
Like calm.
yeah, they just won't stop. And you're like, I don't have anything else I can give them or do for them. So it's very scary. So make sure if they're having it, like I said, several minutes in a row, go ahead and call 911 because it's not going to stop usually on its own. And even if it did stop before 911 gets there, they still need to be observed. Find out what caused it. Okay. Y'all feel okay with all that information from yesterday? Anything different? Any questions?
What was I?
I can make copies if you need.
No, I haven't.
It was a long day. Y'all had a lot of distractions, and it's hard on days that y'all have that ATI. Your brain is done. Yeah, your brain is fried. So, all right. So if you have something that comes up before that, let me know. A question. And then she had made y'all some copies. I guess this looks like it looks like NCLEX questions, or maybe it's from the workbook pages for homework to study on.
Homework.
She just put them in there, so I don't know if it's like a study guide.
Remember that part that was part of our last test? She gave us the answers to it.
I think the answers to workbook questions are online.
That's not working.
This says care of adults with med-surg disorders. Is that
not
yours?
Is this the same thing?
Yeah, same one. I'll find out where they came from. She just had them in a folder to give out. Yeah, we're going to do review.
I just have the book. I have the book to this.
Does it have the answers in it? Regina says she has the answers, so we're going to look. No. Possibly.
Yeah, she usually will give us the answer. Like she did on first.
Y'all have that one? I'll give it back to you. Okay. Did y'all understand the posturing thing that I gave you? This was in your book. It kind of talks about procedures, and I have found another one that might be a little bit better too. It has 3 on it, and I'll make copies of that one. But
One more quick question, sorry. When we go on break, will you go look and see if she has something to say? Oh, okay.
I'm gonna make a copy. And so that'd be a good NCLEX review, good for the unit test. ATI. So were a lot of the questions on the ATI and the ATI book were down that quiz this morning?
Like 5 of them.
just know if they're posturing, they're in a bad seizure. Did anybody need my nervous system notes from A&P? Everybody got those? They were just up here. Maybe she'll be gone. No. Did y'all see on the thing I handed out about the seizures, all the different meds? So just kind of be familiar with definitely Dilantin, Depakote, Tegretol, Neurontin. Those are all very common. And then Keppra. I'm sure y'all given Keppra. You've done clinicals. Y'all give meds? Do you go to clinicals too? Those are all real common and have been around for a long time. And just if you see those names, you'll know that's a seizure med. It's a depressant, CNS depressant. No, I'm winging it. I'm on my own. She had that, yeah. They were like, here you go. What?
And let me evaluate you.
Yeah. All right. Do we need a break?
Yes.
Let's take a break. I gotta do my eyes and ears and see what's going on, and then we'll.
I'm gonna tell her, don't come back.
If we're good on that end, then we'll do our unit review.
Okay.
I'm gonna go make copies of them on break. I guess this is an extra thing.
That's why y'all don't know about me and I do all of them people stuff, but I don't want to count this.
Oh, sorry.
Oh, I forgot you said.
just passed out the.
You sure you just don't wanna go down and say number one is this?
Oh, we could have been. Y'all want to do that, or do you want to do the test?
What was the rationale?
Anyway, it's printing. Thank you. And I'll do the other one. I'm gonna walk into my office and do it first. So are the answers right here? Like 4, 1, 2.
What's wrong with somebody's foot?
These are that.
So is this mine? Have you ever put a test for an OB? Give me your purpose and love. Oh, Lord.
Yeah, you can just put That's the answer. Is that all?
What if you never received it? I received it.
It's not you can go over on the internet. I don't know, you want me to give them to you?
Yes.
Okay. Number 1 is 1, 2, 6. I'll just get it off me later. Okay. 2 is 3. 3, 4. Wait a minute.
Wait, what's going on with you?
We're not to start this motion.
You're supposed to say class, attention, or something. Can I have a highlight?
Where are y'all at?
3.
Right here.
Wait, no. We starting all the way up.
I'm on 1. You're on 1. Okay. 1, 2, 6. Shouldn't that have 3?
Bitch, I'm trying to give me a whole ass highlight. Y'all better leave me the hell alone.
You think that's how I play it?
Okay.
Okay.
Wait, what? Start over.
1, 2, 6 for 1. 2 is 3. 3 is 4. 4
You
is,
going to? No, she not.
4 is 1.
Fuck it. I just did somebody else's number.
Okay, go 5. 5 is 2. 6, 3. 7, 1. 8, 4. 9, 2. 10, 3. 11, 3. 12 is 1, 2, 3, 6. 13, 3. 14, 3. 15, 4. 16, 2. 17 is 4, 5, 6. 18, 2. 19, 4. 22. 21 is 1. 22 is 3. 23 is 4. 24, 1. 25, 2. 26 is 3. 27 is 4. 28, 3. 29, 3. 30 is 1. 31 is 2, 37, 1, 38, 2, 39, 4, 40 is 3, 41 is 3, 42 is 1, 43 is 3, 44 is 2, 45 is 2, 46 is 3, 47 is 1, 48 is 3, 49 is 1, 50 is 3, and 51 is 3, 52 is 4, 53 is 2, 54 is 3, 55 is 1, 56 is 3, 57 is 2, 58 is 4, 59 is 4, 60 is 1, 61 is 2, 62 is 1, 63 is 2, 64 is 1, 2, 3, and 4. 65 is 1. 66 is 3. 67 is 1, 3, 4, 5, and 6. 68 is 2, 3, 4, 5, and 6. 69 is 1, 2, 4, and 5. 70 is 4. 71 is 1, 3, 5. 72 is 2. 73 is 2. 74 is 2. And 75 is 2. 76 is 1, 4, 5, 6. 77 is 3. 78 is 1. 79 is 6, 2, 3, 5, 1, 4. 6, 2, 3, 5, 1, 4. 84. 80 is 4. 81 is 1, 5, 6. 82 is 2. 83 is 1. 84 is 3. 85 is 4. 86 is 3. 87 is 2. 88 is 4. 89 is 4. 90 is 3. 91 is 4. 92 is 2. 93 is 1. 94 is 3. 95 is 4. 96 is 3. 97 and a picture. Yeah. The right hand side. Good. 98 is 1. 99 is 2. 100 is 2. 101 is 1, 3, 5, 6. 102 is 3, 4, 5. And you repeat it.
That was smart. It's
still 20 more minutes on the other stuff, but you at least have answers, and then you should get the rationale to you. Y'all are such good time managers.
Yeah, what? I'm sick of neck happening. 7.
Now she's with child. Remember, she's with child.
Nobody cares. She's sick of me. You get sick every day. Give her a prescription. She'll be fine.
Aww. Okay, I don't think I told y'all one thing, just in case it's on here. There wasn't much in the book, but I did see that there's a question about it on the test. So
It was what?
there's a question, like the movement or like muscle tone and stuff like that. I guess it kind of was talking about it because of like if you've had a stroke, you know how you have the paraplegia or whatever on one or side or whatever. So kind of read over that, and we'll go over it specifically on but like your motor function, that's a change in the strength, your grip, your tone, you know, all that, flexion, spasm, posturing, all of that. If they have unilateral neglect, that can mean that they're unaware of or inattentive to one side of the body, that like they don't even realize that they're weak on that side. That's why they squeeze, like they're squeezing, and you're thinking they don't have any grip on that left side, but it's because they think they're squeezing just as hard. They don't realize it. So kind of read over that section in your book about the muscle tone and stuff. Let me look and show you. Hold on, because I don't remember exactly. Let me get my pages out. I mean, we're going to kind of review it with the test in a minute, but... And y'all know this is only half of chapter 50. Thank you. 1905. This is only half the chapter, right? Next week is when we do the other end of the chapter. See where it says sensory and perceptual status on page 1905? And then motor function. That kind of stuff. So like flaccid, spastic, paresis, all that. Just kind of know those terms, kind of be familiar with that. Okay. Does anybody want to, we're going to review it since we have time. I thought we'd do like a little Unit 2 review for next week. Because Thursday morning we'll do ATI, right? And then we'll come in and maybe start on some new material. And then did y'all say you wanted to do Unit 2 test Friday? Yes. Everybody agreed to Friday? Okay. So that's what we'll do. So let's review for Friday, if y'all want to. Okay. It is recording. Let me make sure. Yes, it is recording. I will put that on my YouTube. So y'all have that. Because I'm good like that. But I got to turn this off because it's hurting. And the slides, remember, the slides will be on there too. On what is it called? Grade book under handouts, class handouts or something like that. Okay. Let me shut that door. Okay. So when we were talking about headaches and migraines and all that stuff, you know, we kind of... Sorry, Chelsea. Thank you for coming. We just shut the door on you. Thank you. We just pass them out. We're fixing to review. Here comes the rationale. Part of them, anyway, I think. So, we're going to go over the Unit 2 review right now, Chelsea. And it'll be on the YouTube, and then if you have your own recording on that. So we talked about migraine headaches. They can be frontal, temporal, they can be one side, right? They usually present unilateral, that means one side, like behind one eye or one ear. They'll come in and they'll say, I feel like I've got something sticking out of my left eye, because like something's just killing me, and it's just on that one side. That's usually an indicator of a migraine, okay? Alright, so like if there was a question that said migraine headaches are characterized by unilateral pain, often behind one ear or one eye. That would be a correct statement, because that's what they're characterized. They usually start off unilateral, meaning one side. Okay? And we talked about putting a cool cloth on the head, just like this morning. That's something that you want to do to help alleviate the feeling of nausea, or just to kind of give them it's more like a nursing comfort. It's a somatic treatment that you can do. Okay, and then like I said, flaccid, that's on page 1905. What's that definition of flaccid? Somebody read it. Weak, soft, flabby, lacking normal muscle tone, not considered flaccid. So if you said their dorsal flexion or pedal, or what is it called, plantar flexion was flaccid, something like that. Know the definition of flaccid. Okay. She's got true and false, some multiple choice. Some matching. That's new. With the word bank. We're gonna talk about it. I'm just kind of saying there's no select all that apply. But I see 40 questions. So that would be good. Alright. So then, don't forget this is over urinary too, right? Not just neuro. Fine with urinary incontinence, might be real depressed and down, because remember we talked about how emotional that is for them. We would want to make sure we're being supportive, right? So you might want to say something like, I know you're upset right now, I know you're discouraged, I know this is awful for you, but we're going to get you what you need, and we're going to find resources for what you need. So you would want to make sure you say something acknowledging that they're discouraged, but then give them a solution. Okay? Cheer up, you can't be serious. That's not something good you want to say. Just say it. The rest of them are kind of obby, but just remember you're trying to encourage that acknowledge that they're upset, and then give them some support. Remember Peridium? Peridium, that drug, Pyridium. Orange pea, is it an antibiotic? No. What does it do? It's just something that takes that stinging and burning away. So that when they're having all that, then they are having a urinary tract infection or kidney infection, it does burn and sting, but the Peridium takes that pain out. It doesn't kill the bacteria or cure that infection. It's not an antibiotic, but it takes the burning and the stinging away. So that's Peridium. Which position do you put a client in for catheterization? Recumbent. That's on the back with the legs. So out of the other choices, I guess that is, you wouldn't want to put them prone, because what is prone? You don't do knee chest, not for a catheter anyway. And lithotomy, they're not going to have stirrups on a bed for a catheter. So recumbent means you're on your bed with your legs just dipped. Okay. Okay. What if I put it in the wrong hole? What would I do if I had the catheter to put it in the wrong hole? Yeah, I cannot use that again because that's considered breaking sterile technique. So know about your catheters. What's the most important kind of lab for a nurse that's caring for a patient with kidney issues? Yep, BUN. Because it's blood, urea, nitrogen. Urea. Zone in on urea, urine. Any kind of kidney patient. Not necessarily, it doesn't say they have an infection. Okay? So be careful with that. There's some tricky wording on there. Okay, if I had blood in my urine, how would it look? Besides red, sorry, that was obvious. Would it be cloudy? No, that's infection. Dark yellow, that's dehydrated. Bright orange, I've got Peridium probably. So maybe smoky, I've never used that term, but I think the book did use the term smoky. For smoky. So the book says if you have red blood cells in your urine, you would inspect it and see that it was smoky. Never used that term. What was the coat color? Something else. Was that? Okay, what does oliguria mean? So if I'm in the oliguric phase of renal failure, okay, the nurse would anticipate the client's urine output to be what? So I'm having low output. That's what I would have said, but that's not on here. So oliguric phase, I think it was in the book, so they're saying for the oliguric phase, it would be 100 to 500 a day. Yes. So make sure you look up oliguric phase and know of a renal failure patient. Because remember, we talked about when they go into those different phases of renal failure. They dialyze them and then they diurese them and then they give them more and all that. So know that. Know those phases of renal failure. But 100 to 500 a day is where you would expect it to be. Okay, acute renal failure. Make sure you're reading the words carefully because these are test-based questions and you know how they like to be. So, nursing assessment is essential to add to the client's care plan for a patient in renal failure. What would you want to put on there? Let's see. What's the main thing for renal failure? The nursing measure that I told y'all to always look at. Yes, I know. Wait, but it's not on there. So I know it's always your good one that you want to look for because we're monitoring fluid, right? I know. Intake and output. Okay, I can't have salt because I'm a sodium restricted diet patient. What can I have to substitute for that? So then I'm still thirsty. I don't like lemon. So what do you give them? Yes. We could give them hard candy. So they're saying they're thirsty and they can't have fluids. They're on fluid restrictions, you know. But I want ice chips. Does that still count as fluid?
Yes.
Yep. So you can't have ice chips. But I want an ice cream bar. But I want fresh fruit. I can only give you hard candy. Everything else is considered intake, and it breaks down into fluid. Okay. What did we say? I think Sam was the one that said when you're doing dialysis, peritoneal dialysis, the one where you give them fluid through their abdomen, but with any dialysis patient. What's the first thing you do before dialysis, or the last thing you do? Weights. Correct. And then what, if they're having peritoneal dialysis, what is their highest risk besides the kidney issues? What are we worried about? Infection, because we're sticking that catheter in and out of their abdomen all day long. Remember to dialyze them. That's the one they can do by themselves. They don't have to have a machine doing it. And so we worry about infection. And what is our number one thing that we see when somebody has an infection? Our vital sign. Fever. Fever. Increased temp. Good. If I was telling somebody about the potential complications associated with peritoneal dialysis, this is 3 in a row. Which complication is the most important to include? We kind of talked about that. Just know that they're at high risk for infection. And what does itis mean?
I-T-I-S. So if it says itis on the end of anything, that means infection, right? Even if you don't know the word in front of it.
I thought it was inflammation.
It is infection, inflammation. Which assessment findings strongly suggest that a client's reduced volume of voided urine is due to an obstructive disorder, such as an enlarged prostate gland. So when you have somebody that has an enlarged prostate, are they going to be peeing from here to the wall? No. What is their stream like? Yes, it's very weak stream. They have hard time starting and stopping because that prostate is wrapped around their urethra, remember, and they can't get the urine out. And they feel the need to void, like they feel it because their nerves all still work. They just can't get it out. There's an obstruction there. So they will feel a need to void, okay? Yeah. They feel like they need to void, they just can't get it out. Feel. Actually, what's the kind of catheter that I use if I have an enlarged prostate? Thank you. A Coude. C-O-U-D-E. Coude catheter. She will never miss that question. If you miss it on your NCLEX, I'm going to come find you and beat you. C-O-U-D-E. That's the kind of catheter. Remember I said there's all the different kind of catheters, and that's the one you have to use for an enlarged prostate because it can help wiggle around that big prostate. Y'all thank Ashley for that when y'all get that question right. Okay, if you were taking a patient in, like a new patient, and you're interviewing them, and they have BPH, what's that stand for? BPH. Prostatic hypertrophy. It means that prostate has enlarged. Hypertrophy means too much. Just like atrophy means not enough tone, hyper means it's got too much, so the prostate's big. So BPH means enlarged prostate. If they have that, and you're interviewing them, what are some of the questions you want to ask them? So would you ask them about lumps in their scrotum recently? That might come up later, but not when we're talking about first. Our most important thing is elimination, right? Do you have difficult time starting to void? Alright, because we just talked about that. Their prostate's enlarged, they can't get it out. Are you embarrassed to ask them that, Devin?
No.
Well, some of the other questions are quite embarrassing, the responses they give, so they're kind of embarrassing here. Not necessarily controlling it, because they don't have incontinence. They can control it, they just can't get it to stop because it's blocked. Okay, so know that. Know there's a difference. You have difficulty starting to void. Okay, that's what you want to know about a prostate person. Okay, a cystoscope, what's that? Cyst means, or cysto is bladder, scope. So they've taken that bladder, scope and gone through the bladder, and they're now with you. They've already had the procedure. What would you expect to see? And they're like, would they have pretty clean urine? What would they have? A little bit of blood tinged. Would they feel fine and go in there and pee a gallon? They probably have a little pain or burning, right? Because this tube just ran up their urethra. So now all that tissue is inflamed and swollen, so it's tender. They have dysuria. It burns coming out because we just ran something up a place that shouldn't have anything rammed up it, right? And so it's burning and tingling and hurting on the way out. So that's dysuria. You would expect that after a cystoscope. Yeah, just dysuria. Maybe even a little bit like, I want to pee, but I can't because it's all swollen. What is urolithiasis? Kidney stones.
What was it?
Kidney stones. So, kind of kidney stones. What are some of the things we do for that? I gave you a little handout.
Draining it.
encourage fluids and activity, because if they can get up and walk around and they feel like it, that might help it move too. But increase fluids, because it'll help it pass, and then also it may prevent one from forming.
What was the word you said for that?
Euro, and then lift, Lithiasis. That is another word for kidney stones. Okay, so we want to make sure they're straining their urine. We want to make sure that they're getting plenty of fluid, more fluid really, so that we can push that through and get it out, and it'll prevent further ones from forming. Well, we want to increase their calcium. Why? Alright, that's counterproductive. That's going to make more. Okay. Make sure you're reading all of your responses.
Did you already go through the maximum?
No, we're almost there. What about bladder spasms? I talked about that. What do you give somebody if they're having bladder spasms? B&O suppository, the belladonna and the opium suppository, because that's an opiate and that's a smooth muscle. Isn't your bladder smooth muscle? B&O, like not B-O. B&O, belladonna and opiates, because it's gonna help that smooth muscle. They're having spasms of the bladder, so this relaxes the bladder. We talked about that. We're going to get into neuro. So that was 22 for neuro. So just hit all your highlights and look at those. Know the prostate, know the UTI stuff. Okay, so Glasgow Coma Scale, same kind of situation here. They give you a little situation and you need to tell us what, they tell you what he's doing, and you have to give his score. Okay?
Does it say if a client has become unresponsive except for painful stimuli? Is that how that question starts? Just out of curiosity.
No, it doesn't.
No, that's what I'm gonna look at. What was it?
So if he's drowsy but responds to verbal commands, what would that be? Let's look up his points. Let's practice it.
Like 8.
Where is it at in our book? What page? I can't just give it to you. I want you to figure it out.
No, but I was asking because I was hearing that question.
Yeah. We're going to do this one together. That way if you don't understand it, maybe you'll get it.
Response to pain.
What page are we on that? What? 1903. Alright, so let's look at it. Remember how you're going to count up each point. Each category. So he is drowsy, but responds to verbal commands. So what would you give him on that? How many points?
3.
He opens his eyes when the nurse calls his name. Is it in the same category? 3. Is it in the same category then? So then he only gets 3. Alright. Because he's drowsy, but he's responding to verbal commands, and he opens his eyes when the nurse calls his name. Is that all in the same category? Yes. So there's 3. He's oriented to time, place, and person. Okay. So you guesstimate 8. What if 8's not on here?
9, 7.
Pick your highest number closest to 8.
Oh, highest number.
Because we went by 8. But if 8's not one of your options, what do have scored. Okay, we talked about EEGs. We didn't talk about that today. What is the thing you tell them? Yeah, wash their hair the morning of, and they need to stay awake. EEG. That's the electroencephalogram. They just put the leads on your head, and then you sleep. So that's the one we want them to try to stay awake all night, right? So that they get a good rest. Because then they'll get up there to the hospital if they slept all night, and they're like staring at the ceiling going, I can't sleep. I can't sleep. And then you're not going to get a good, accurate picture of their neuro. So you make them stay up all night. It takes a long time. It's not a 15-minute process. Okay? Do they need to lay flat afterwards? After the test, they do not, because we haven't done anything invasive. We just put leads on their head so they can sleep. So that one wouldn't apply. They do need to wash their hair. Read these carefully, okay? You want them to wash their hair, and you want them to stay up all night. Okay, you've had somebody that just had a seizure. What should you do first? Always. Sideline position and covering position. You already knew all of this. You didn't even need this. When you have a patient that has seizures, like that's their diagnosis, they're therefore maybe it's a new diagnosis or a new or recurrent onset because they stopped taking their meds or whatever. What would be the safest position you want to put the bed in? Always. Think about fall precautions and safety. Because if you're not in there and they have a seizure, we don't want them rolling off the bed. And if they do, we want it to be as low as possible. Less of an injury. Okay. Talked about hair again. She has some really random questions. Just make sure their hair is washed. If they didn't do it at home, what if they get up there and say, no, I haven't washed it in a week. You have to help them wash it. Because it's going to be oily and the leaves won't stick. Are y'all laughing at greasy hair?
Depends on the culture.
Well, if you're having an EEG, don't put any in the morning of, okay? So that'll be another test. There's an EEG test. What we say when we're documenting a seizure, I'm glad we remember all this. What's the most important thing to include initially?
How long it lasts.
Duration of the seizure. How long? Duration means how long it lasted. So duration of a seizure, that's definitely most important because remember that tells the doctor a lot of information. Is it just something that they always have, or is this longer? Is it new? Is it status epilepticus? Is it a different area of their brain? So we always want to know how long it is, the duration. Okay, so we talked about today about when they have a seizure, they go into that deep sleep, which is called what? Good. Post-ictal. And then, are they going to be alert and oriented after that? What are they going to be? Decreased, level of consciousness, confused. You may have to reorient them and reassure them and tell them that they're safe. So remember that. And then, what are you watching for while they're post-ictal? You've already helped them. You're sitting with them until help arrives, and now they're sleeping. What are you as the nurse supposed to watch for while they're in post-ictal? What are you assessing? After the seizure, they're resting. They're sleeping. How long they sleep. But what else? What's our ABCs? Breathing. Yeah. Airways open because I got them on their left side or on their side, so I know their airways patent. They're breathing. I want to see, are they breathing panting or are they breathing normal, slow? I'm going to look at the color. So respiration effort. Watch their breathing pattern, okay? Because remember, they're unconscious and their brain's not working, so what if they stop breathing and you're not watching them? That's why we monitor them afterwards. Okay. Almost a little few more. Migraine, headache, foods. What were the foods that you tell they may cause a headache? So what do you tell the client to avoid if they have migraines? What about salted
would they be? A client that has a bladder infection, select all that apply for the symptoms.
Urgency, dysuria, hematuria.
So they're going to have flank pain because it didn't say, it says bladder, but when we talk about in class, it's the back is the kidney, so I guess you could have flank meaning side either way. Flank pain, okay? They're definitely, according to this, they're going to have it. Strong smelling urine because it's infection, right? So they're going to have that real strong pee that stinks. It's going to burn, right?
Yep.
Because it's infected. Are they going to have the urgency and frequency? They're going to go. They've got to get in there, and then they only pee a little bit. So their frequency is constant. They're having to go every 5 minutes, but then it's just a little bit. So know those. Okay, and then this was on our little picture I gave y'all. What do you do to reduce bacterial growth in a female client's bladder? Tell me some things you would do. Wipe front to back.
Pete, going after sex.
I was waiting on
I
you.
knew I was going.
Crazy thing. So yes, you urinate after sexual intercourse because that flushes the urinary tract. And you drink lots of fluids, right? We did talk about that you could drink fluids that are high in acid because that would change the pH. But that is not recommended on this test. I still recommend it, but I would not mark that one. Direct bladder infection teaching. So basically, drink large quantities of fluid and void after intercourse. Yeah, if that's on there. Do I have to avoid using public restrooms? That's weird. Some of these tests I focus on. Okay, glomerular nephritis. What was that? That's our. Yep, they've had strep throat. Now 2 or 3 weeks later, I've got that strep trapped down in my kidney in my glomeruli.
Streptococcal.
Streptococcal. Don't get me saying it wrong. You know I can't talk anyway. Okay, so if they had that, tell me what this is hard to. I'm just gonna read it. Which statements made by the client's spouse most closely correlate with the diagnosis of acute glomerular nephritis? So like all apply. On here,
They're like, have you had strep or something like that?
when her face, if he said, my spouse's face looks rather puffy lately. See, I wouldn't have picked that one either because that was on renal failure. But this is glomerular nephritis, so I guess they're saying like the kidney is swollen and it's not working, so they're retaining fluid periorbital. So we're gonna go with that. Yeah, they look puffy lately in their face. What about my wife's appetite? Would it be, if he's gonna say something about her appetite, would she have a good appetite or a bad appetite? Yeah. She's not one to eat because she hasn't been eating very well because she feels bad. She's sick. Her body's already full of that toxin because it's not been able to get rid of it, so her appetite's gone. And is she going to get up and go to the bathroom a lot? Yeah, she's going to get up at night to use the bathroom, according to this. So she's got a puffy face, she doesn't eat very well, and she's going up to the bathroom all night. Okay? It doesn't, on here it doesn't think, it says that she might be she's forgetful lately, or that she's been salting her food heavily, and that she sleeps a lot. This is a crazy question, so just know that their face is puffy, they don't have a good appetite, and they get up at night to use the bathroom. Just read over your glomerular nephritis.
Thank you.
Okay, and then, we didn't even talk about this one, so, if they had glomerular nephritis, which finding would the nurse expect to observe when conducting a head-to-toe physical assessment? Would they have skin hemorrhages, a flushed appearance?
Yes.
See, I thought that too. And peripheral edema? Yes. They're gonna have peripheral edema because remember their kidneys aren't working as well, so they're retaining some fluid. But but flushed appearance is not considered correct.
What's the name?
So just can you not say that out loud? Peripheral edema is what you would expect to find, right? Because their kidneys aren't secreting everything. Doesn't have anything to do with body hair or skin hemorrhages, okay? Just know that they're going to have a lot of edema. Well, okay, we talked about urolithiasis again, another kidney stone. We're almost done. We talked about you want to strain their urine and you definitely want to give them the antibiotics, okay? Do we want to put a catheter in anybody with a kidney stone? No. We talked about that already. And then do we want to restrict fluids? No. We want to increase fluids, okay? So read these choices carefully. And it doesn't matter about the position in the bed. High Fowlers, that's irrelevant. Fowlers, doesn't matter. They just threw that in to confuse you. So just know, with a kidney stone, you're going to strain their urine and push fluids. And then you're going to give them their antibiotics that the doctor's orders. Okay? Not restrict fluids. You're going to push fluid. And give them more. Bladder cancer, what do y'all remember anything about that? The causes? Infections, chronic infections. What's that is on here, but that is not the third thing. I would have thought that too, because I thought we talked about
I
that.
could have sworn we did too.
Cigarette smoking and a history of prostate cancer.
Yeah.
Those are what are your main factors that are linked to bladder cancer. Okay. History of or prostate cancer. I'm sorry. I think I said it wrong. They already had prostate cancer and they're a cigarette smoker, then more than likely they're going to have bladder cancer. So that's going. You have a patient. We're on 38. There's two more. A nurse is reviewing triggering factors that cause seizures. And this is a newly diagnosed seizure patient. What are the factors that the nurse should include, like some of the triggers?
Bright light, alcohol.
Acute alcohol intake, exposure to bright lights for sure, and then excessive fatigue. Remember, they just may have not slept in days, and they finally just their brain shuts down. It's like I need sleep. Flashing bright lights. Exposure to bright lights. That can cause that could be a trigger for a seizure patient. You're educating a newly diagnosed seizure patient. So you tell them you have to sleep. Excessive fatigue can trigger a seizure. And you tell them you cannot drink acute alcohol intake. It has to be limited to none because you're on seizure meds and they're already suppressing you. If you pour alcohol in it, it's going to make it decrease your respiration. And then you tell them to avoid exposure to bright lights. Okay. That's all you have to tell them on this. There's some other good stuff, but don't tell them that. This day. She's killing me. Okay, seizure disorders. Again. Let's see. Do we ever restrain anybody having a seizure? No. You just protect their head, remember? You don't want to hold them down because then that could be, you could do more damage. You could hurt their neck or back. So we don't restrain somebody having a seizure. We want to provide privacy, right? So if they have that aura and they say, I feel like I'm fixing to have a seizure, you try to help them get somewhere safe or private if you can. You need to sit down, ease them to the floor before they fall, okay? Do we put anything in their mouth ever?
No.
Do I loosen their clothes around their neck?
Yes. Do I protect our head?
Yes.
Okay. Cluster headaches, we really didn't go into detail about that, so kind of read on that when you're studying, and then know what to expect if you had a patient that has a history of that. So they may have nasal congestion or drainage. They may have headaches that occur at the same time every day. Yeah, it's cluster. It's kind of a pattern thing. And they may have that altered sleep-wake cycle. Okay? If it's dull and throbbing, that's more of a migraine. If it's bilateral across from the back and forth, that's something else. So clusters are at the same time every day. They have an altered sleep-wake cycle, and then they have nasal congestion and drainage a lot. How many pairs of spinal nerves are there? Make sure that you read it good. If it's spinal nerves or cranial nerves, don't get in a hurry. But spinal nerves is 31. Cranial nerves is response characterized by flexion of the arms, wrists, and fingers, with adduction of the upper extremities and extensions, internal rotation, and plantar flexion of the lower extremities. My goodness. Which position is that? The corticus. It is the corticus. Correct. That one threw me. I had to stop and draw a picture. That was the handout that I sent gave y'all, right? But the last ones are matching. So prodromal signs that occur before headaches. Do y'all know what prodromal means? Aura. Yeah. Like a precursor or a warning. Aura. Widening pulse pressure, bradycardia, and abnormal respiration. What is that? What is that? We didn't talk about it, but it was in your reading. Y'all didn't read. It's Cushing. I think it was on that thing, on that handout I gave you. If they have those three, that's a cardinal sign. Those three things is Cushing. Response. Okay, it's called Cushing's. When they have a widening pulse pressure, now they're bradycardic because their heart rate's going down and their respirations are crazy. That's called Cushing's response. Okay? They have to have those three things to have Cushing's.
Okay, so the widening pulse, respiration is crazy.
A widening pulse pressure, where it's the margins getting wider and wider, and then they're bradycardic, which means their heart rate's low, and then their abnormal respirations, they're probably breathing fast. Okay. Cranial nerves are 12. All four extremities are in a rigid extension with hyperpronation of forearms and plantar flexion of the feet. That's the other one. The Sarah group. So, know those in your head. What is double vision called? Diplopia. When do they have double vision? What would you expect them to say that? Intracranial pressure or the seizure? Yeah. Difficult articulated speech. And if that's not on here, it's dysarthria. I think dysphagia is swallowing. Dysphagia is swallowing. So dysarthria is difficulty with speech. Because remember, it's not just the vocal, it's the written, writing, and all that. So arthria, like arthria. I hope you remember that one. Aphasia is no speech. A. You didn't catch that. Trying to holler. Difficulty swallowing is dysphagia. So all of that's on there. So make sure you know the difference, okay? Last one. Abnormal neurological condition in which language is defective. A.
questions on anything? Okay, y'all have a good weekend.